is my teacher. In front of the class, he says if you're not a believer, if you
Hello, and I'm so excited to present to you the National Leprosy Eradication Program. It is the one program, it is the only program which has the word eradication. That means what is the focus of the program? The focus of the program is to finish off leprosy at the first place. In this video module, we are also going to talk a little bit about leprosy. Of course, leprosy has been done beautifully and in a very scientific manner by Dr. Malcolm sir in your dermatology sessions. So primarily in this video module, I'll be giving you a basics in leprosy, and then we'll be switching over to the National Leprosy Eradication Program. We are going to talk about the oldest disease known to mankind, and also which is called as the Hansen's disease. So let us move forward and talk a little bit about leprosy first. Leprosy, that is the oldest disease. What are the agent factors? Leprosy is caused by Mycobacterium leprae. Mycobacterium leprae is an acid-fast bacilli. Mycobacterium leprae has a particular predilection to affect the Schwann cells and the reticuloendothelial cells, endothelial system, or the cells in the reticuloendothelial system. This Mycobacterium leprae is also known to occur in clumps. It occurs in clumps that is called as globi. In clumps, these are which are called as the globi. So that was just a brief about the agent factors. Next is, what are the source factors? Like, what is the source? Please note that leprosy is now very recently the researchers have shown that leprosy is also there in animals, but we are not sure. The animal source is not known. It is not known. The only source is a human. A case of leprosy is the only source. Talking about the infectivity parameters, please note that leprosy is a highly infectious disease, but it has low pathogenicity. The potential to cause a disease is kind of low. It is highly infectious but low pathogenicity. In fact, if I just talk to you about the infectivity potential of leprosy, it is known to cause leprosy in roughly around 4 to 12% of cases of contacts, close contacts will develop leprosy within 5 years. They will develop leprosy within 5 years. So that is what is the infectivity potential of leprosy. Talking a little bit about the host factors, it is known to be there mostly in the middle age, with the peak of leprosy cases in 20s to 40 years of age. It is predominantly more in males compared to the females, probably because the males would have more contact with other people. So just based on that, otherwise there is no biological reason for leprosy to be more in males. And it is more, very huge, large number of subclinical cases compared to the clinical cases. So why does this happen? Why do people have more amount of subclinical cases? It is predominantly because it is dependent on the cell-mediated immunity. It is known that cell-mediated immunity is known to affect the cases happening of leprosy. More low is the cell-mediated immunity, the more severe the leprosy will be. So if the cell-mediated immunity is good enough, probably the patient will have tuberculoid type of leprosy. If the cell-mediated immunity is very low, probably the patient will have a multibacillary or a lepromatous type of leprosy. That was about the host factors. Environmental factors. Environmental factors in leprosy. It is known to affect people because leprosy has a very long incubation period. It doesn't happen in some seasons, right? It doesn't happen more in summers or winters, but it is seen that areas where more dense population, where there is more dense population or there is overcrowding, there the leprosy spreads more due to common sense reasons, because it has more modes of transmission, would be more close, people will be more close, right? So more dense population, more overcrowding, and it is because of more dense or more overcrowding, it is slightly more in winter seasons. It is slightly reported more in winter seasons. And if you talk about the environmental factors for the lepra bacilli, do you know that in the dried nose secretions, the lepra bacilli can live up till 9 days, whereas in a soft soil at optimum temperature, optimum means at room temperature, at normal temperature, the lepra bacilli can live up till 45 days. So that's like 1.5 months the lepra bacilli can be staying over there. So these are some of the agent, host, environmental factors. Based on this, what is the modes of transmission and what is the incubation period? The incubation period of leprosy is very long, that is 5 to 7 years. And some researchers have also told that the lepra bacilli can have the incubation period of more than 12 years also, right? What is the mode of transmission has been many times asked in your exams. What is the mode of transmission? The mode of transmission is primarily the droplet mode. Next in line, it could be contact. But what means direct contact? Is it through soil? Is it through fomites? Is it through unclean hands? Is it through direct body secretions? We don't know. But yes, droplet is definitely one of the main mode of transmission. And how does droplet affect? It is more from what is the portal of exit? It is from the nasal secretions. Nasal secretions is the portal of exit. It is the portal of exit. So you just need to understand these points. There has been some research with saying that using needles or through the vectors also leprosy can spread, but all said and done for MCQ exam, just remember it is droplet and the incubation period is 5 to 7 years. And now with that understanding, let us now talk about the National Leprosy Eradication Program. See, what happened was that early in 19th and 20th century, in 1948, many social organizations had already started coming up for leprosy. There were many religious organizations, many social organizations on a very big scale. But one of the most defined societal organization helping leprosy was the Hind Kush Nivaran Sangh. After a very good and a successful response from this Hind Kush Nivaran Sangh, then subsequently in 1983, the National Leprosy Control Program, followed which the National Leprosy Eradication Program was formed. Every year, the World Leprosy Day is celebrated on 30th of January every year, and the theme for 30th January 2022 is Unite for Dignity. So the people who have already suffered leprosy, for them this year was to unite for dignity. And these are just 2 MCQs you would like to remember for your exam. Coming next is topic number 2 in your National Leprosy Eradication Program is what are the targets. In all the national programs, I think I have undergone this system or this strategy that we are going to talk about the targets, the strategies, the organization and the indicator of the program, that is TSOI, the targets, strategy, the organization and indicator. So let us talk about leprosy program in these 4 headings. What are the targets? Beta, the targets of leprosy program is to have a prevalence rate of less than 1 per 10,000. The denominator is kind of funny. It is 10,000. It is not 1,000. It is not 1 lakh. Another target of the program is also to have the ANCDR, the annual new case detection rate. It is to have the annual new case detection rate of less than 10 per lakh population. So kind of denominators are important for you to understand. And if you just look at these numbers very closely, don't you think, I'm not quoting myself, I'm not quoting anyone, don't you think they both are meaning the same? One per less than 1 per 10,000. But ANCDR is taken as per lakh and prevalence rate is taken as per 10,000. That is the target. Topic number 2. What are the strategies of the program? The first strategy of the program is to have early diagnosis and prompt treatment. What do you mean by early diagnosis? Diagnosis means to diagnose the leprosy at a very early stage. So how do you diagnose? Please note that the Ridley-Joplin classification or the Indian type of classification, where you have a tuberculoid leprosy and you have one extreme is tuberculoid leprosy, another extreme is lepromatous leprosy. And as you move from tuberculoid leprosy towards the lepromatous leprosy, the severity would definitely increase. So technically, we do not use in this program for diagnostic modality, and for treatment modality we do not use this. What we use in our program is something very simple. The diagnosis is based on two modalities. Either we can have a paucibacillary leprosy or we can have a multibacillary leprosy. So first criteria, how to differentiate between a paucibacillary and a multibacillary leprosy. The first criteria is regarding the lesions. If there are less than or equal to 5 lesions, that is called as a paucibacillary. Pauci means less. Also, if you talk about the nerve involvement, the nerves involved are no nerve involvement or one nerve involvement. That is called as a paucibacillary. And if you talk about the skin smear examination, there is no positive, all are negative. All the skin smears are negative. There is no positive skin smear examination. This is the criteria for diagnosing paucibacillary leprosy. On the other hand, what is multibacillary leprosy? Common sense. More than or equal to 6 lesions is multibacillary. If there are 2 or more nerve involvement, that will be multibacillary. Any skin smear positive is called as a multibacillary leprosy. So please note that what do we mean by pauci and multi. What is paucibacillary? Paucibacillary is lesions less than or equal to 5 lesions in the body, on the body. So MCQ will come as, what do you mean by lesion? What is a lesion? So beta, lesions could be of many types. The skin lesions could be a reddish kind of skin lesion, or it could be hyperpigmented, hypopigmented, it could be anything. It could be with anesthesia, or the anesthesia could be maintained or not maintained. So please note, most common type of skin lesion would be a the most characteristic would be a hypopigmented lesion, and there is less anesthesia. Hypoanesthetic, and a hypopigmented patch is what is a characteristic feature in leprosy. And next MCQ, which of the following is the most characteristic? Is it hypopigmentation or hypoanesthetic? Please note, hypoanesthetic is most specific skin lesion that we have in leprosy. If you just look at the special features of leprosy again, so there is a special saddle nose deformity. There will be thickening of the lobule of the ear, and the skin will be very shiny. So these are some related features, but what is the most characteristic feature based on which we will define whether it is leprosy, yes or no, or whether it is a pauci or a multibacillary? It is based on the skin lesions, hypopigmented, hypoanesthetic. Next MCQ which the examiner may ask you is, what do you mean by nerve involvement? What do you mean by nerve involvement? If you talk about the nerves involved, different types of nerves may be involved. We could involve the median nerve, facial nerve, radial, posterior tibial, or the common peroneal. But which is the most common nerve? Please note that the most common nerve involvement is ulnar nerve. What do you actually mean by nerve involvement? Nerve involvement actually means a thickening of the nerve. There could also be, along with the thickening, there could be a neural deficit. What type of neural deficit? Sensory or motor? Please note, it is the sensory deficit which is more specific for leprosy rather than a motor deficit. So it is a sensory loss and thickening of the nerves which is more important, and thickening of nerves is characteristic feature. It is one of the typical features. It is the typical features in leprosy. So now, just to reinforce what is POSI, please note POSI is 1 to 5 skin patches with definite sensory loss. There is maximum one thickened nerve, no thick nerve, or maximum we can have is one thickened nerve with loss of nerve function, and the skin smears are all negative. That is what is a POSI bacillary. If you talk about multibacillary, there has to be more than 6 or 6 lesions which are there with two or more than two nerve involvements, and the skin smear is positive. Please note that the skin smear we can either take a bacteriological index, or we can have a morphologic index. The bacteriological index is going to tell you what it tells you about the bacterial load, how much mycobacteria are there. So that the mycobacteria could be living mycobacteria, could be dead mycobacteria. That is the bacteriological index. That is what is BI. Talking about the morphologic index, the morphologic index will test you only about the good. It is the solid stained bacilli. The staining of the bacilli, when it is done, it is usually a solid stain bacilli. It could be less stain, less amount, and it could be granular staining also. So if it is a solid stained bacilli, that actually means about the live bacilli. It also means about the replicating bacilli. So the morphological index is technically more used for resistance in leprosy, and it is going to tell you about the live bacilli. That is what is morphologic index. In the skin smears, in the NLEP program, we talk about the bacteriological index, which is going to tell you about the load of the bacilli, that is the live bacilli and the dead bacilli both. So just to reinforce what is POSI and what is multi, you can see on the screen, and this, please note, is the logo of the National Leprosy Eradication Program. In this logo, there is a person's hand, and in the hand there is a sun which is glowing. This sun means the rays of hope. Hope means the MDT that we are giving. What do you mean by MDT, beta? MDT stands for multi-drug therapy. Please note, in community medicine, you must have come across a lot of words. What is ATT? ATT stands for anti-tubercular treatment or therapy. ART stands for ART. It stands for anti-retroviral therapy or treatment. Then is MDT. It stands for multi-drug treatment. And then you also have MDA. MDA stands for mass drug administration, which is done for, MDA is done for what? It is done for lymphatic filariasis. MDT is done for leprosy. ART is done for HIV. ATT is done for tuberculosis. And of course, you also have ACT, that is artemisinin. It's not artesunate, arteether. It is artemisinin based combination therapy, which is done for malaria. So a lot of names you have, lot of treatment modalities you have. So I would like you to remember, we are talking about the logo. The logo is the ray of hope, and this is what is the multi-drug therapy, that is the ray of hope. And what is this hand denoting? The hand denotes the hand of the government. So the NLEP program is there. And what is this flower is there? This lotus flower. This is a lotus flower which denotes the leprosy patient. It denotes the leprosy patient, that the program is going to keep the leprosy patients with the delicacy, and they also have a ray of hope. So that was regarding the early diagnosis part of leprosy. So now once you diagnose leprosy, don't you think that we should also be treating leprosy? There should be a prompt treatment. So now your problems start. Beta, for the treatment of leprosy, I would like to tell you that two different regimes are there. One is a WHO regime, one is a NLEP regime. Government of India till 2022, they have not yet implemented the new WHO regime across the country. In India, we are still following our conventional 2-drug for posse and 3-drug for multi-regime. I'm going to discuss all the regimes, but I'm going to give you a disclaimer right now, because a lot of times students get confused that sir told something else, dermatology faculty told something else, in the book there is something else, on the internet there is something else. So what will I do? So I'm just trying to resolve the controversies, beta. There are two types of treatment modalities. WHO gave a new treatment in year 2018. They said that you should give 3 drugs for paucibacillary for 6 months, and they told that you should give 3 drugs only for multibacillary for 12 months. Government of India, National Leprosy Eradication Program, we already have so much. We have invested so much in the drugs. You know, there are different blister packets, MDTs there. So that MDT was already there with us, and the program is having a good response by the people also. So there was, it was kind of decided not to do the transition to the WHO regime. So in NLP regime, it is still followed the same answer that you can have a paucibacillary where we are giving a 2-drug regime for 6 months, and we have a multibacillary regime where we are giving 3 drugs for 12 months. Are we clear with this? So now let me just take you over and talk about the National Leprosy Eradication Program, the MDT that we are giving in Government of India under the National Leprosy Eradication Program. Please note that under the NLEP, the drugs that we are giving are called as MDT, that is the multi-drug therapy. That is the multi-drug therapy that we give in leprosy program. Please note, in the multi-drug therapy, the standard rule is that in tuberculosis, you remember that in TB you had intensive phase and continuation phase. In leprosy, in the MDT, we have something called as a supervised dose, and we have a non-supervised doses. So every month there will be one day, there will be only one day which is a supervised dose, and the subsequent days will be non-supervised dose. So one day will be supervised. So now you can understand what is the treatment that we are giving in NLEP. So you already know there is a paucibacillary. So what we are giving is rifampicin in paucibacillary, rifampicin, and we are also giving dapsone. Please note that rifampicin is given as monthly dose. So that means in monthly, that means it is only one dose which is supervised. And dapsone is given as daily dose. Okay. In case we are talking of adults, the adult means age more than 14 years. Okay. Adult means age more than, every word is MCQ beta. Adult means age more than 14 years. So if you're talking about rifampicin, it is given at the dose of 600 milligram to the adult once every month. That is a supervised dose. The dapsone is given at the dose of 100 milligrams daily. That means one day it will be under the supervised dose, and subsequent days will be non-supervised dapsone doses, right? So this treatment for paucibacillary has to go on for 6 months. So that was the dose for the adults. Now in case the question says, tell me the dose for the child. MCQ number 1 is, who is a child in the leprosy? So as per the leprosy program, who is a child? It is 10 to 14 years. Please note, child is not anything less than 10. 10 to 14 year is the standard MDT that we have in leprosy program. Below than 10 years, also we have the treatment, but that is given as per kg body weight. So 10 to 14 years child, what is the dose of rifampicin? We are going to give 450 milligrams of rifampicin. And in case we are talking of dapsone, it is given as daily dose, 50 milligram of dapsone to the child in the daily dose. Now in case, let us go and talk about the multibacillary leprosy. In multibacillary leprosy, again same answers. We are going to give rifampicin, plus we are going to give dapsone. Now we also add another drug, that is clofazimine. Clofazimine is added. So in case we are talking of the adult, what is the dose of rifampicin? It is given as 600 milligrams. Same answer, it is given as monthly dose. that is the supervised doses. In case of Dapsone, please note it is a daily dose and it is given at the dose of 100 milligrams, same answer. Now, in case it is clofazimine, it is given as both doses. It is given as a monthly dose, which is the supervised dose. It is given at the dose of 300 milligrams of clofazimine on day 1, that is on the supervised dose. And if we are talking of daily dose, it is given at the dose of 50 milligram to the patient every day. In case the MCQ wala asks you about the child doses, in case it is a child, so the rifampicin, again same answer, it was supervised doses is 600 in adult, and in child it is given at the rate of 450. It is the same answer that you have for the paucibacillary. Dapsone, same answer, it is given at the dose of 50 milligram for the child, 50 milligram every day for the child. In case of clofazimine, the 300 will reduce to half at the rate of 150 milligram, and please note that the daily dose of clofazimine is 50 milligram, and in child also it is 50 milligram, but this 50 milligram is on alternate days. This 50 milligram is on alternate days. So these are kind of MCQs which you may get in your exam regarding the multibacillary, and multibacillary is given for 12 months. Please note, paucibacillary given for 6 months and multibacillary is given for 12 months according to these doses. Who is adult? Please note, adult is more than 14 years, child is 10 to 14 years. 10 to 14 years is a child. We are still on the treatment modality. Another point for you to know is what are the colors of the multi-drug therapy which are available in Government of India. So in India, we are having paucibacillary and multibacillary. Common sense, we already know that. You could be adult, or the patient could be adult, or the patient could be a child. Who is a child? 10 to 14 years. We already did this. So the multibacillary could be adult or the multibacillary could be a child. Just remember this. So if you talk about the adult or the child, or in pauci or in multi, so paucibacillary. The adult paucibacillary is a green colored blister, the multi-drug therapy. The child paucibacillary is a blue color blister. In the multibacillary, what is multicolor? It's a dangerous color. What is the dangerous color? That is the red color. So in multibacillary adult, it is a red color blister packet. It is a red color blister packet. And the multibacillary in the child, in the chota bacha, in the child, it is a brown color blister packet. So how I have remembered is very simple. I'll just share you my trick. So how I have remembered is B for brown, B for blue, B for bacha. So you can remember bacha or the baby or the bacha or the brown or the blue. Just remember all B's are together, right? So you can remember, of course, common sense. Anybody would say that paucibacillary is a blue and multibacillary would be brown because we are talking of a dangerous color. So that was your point number 2 in early diagnosis and prompt treatment. So beta, what you have done till now is strategy number 1. We talked about the diagnosis of leprosy and about the treatment of leprosy. The strategy number 2. That people with leprosy, they will have thickening of nerves, they will have sensory loss, and because of sensory loss, they will also have motor loss later on. So this causes some disabilities. So because of disabilities, the government was doing free reconstructive surgeries for the patients of leprosy. Plus, the government is also providing free prosthesis. Plus, the government is also providing the free MCR footwear. That is a medical grade rubber. So MCR footwear, that is for specialized footwear for the leprosy cases, because there is a sensory loss. And a lot of times the people will have numbness, and because they cannot sense the injury to the foot, and there is a lot of problems, ulcers, and so many things will happen, secondary infections due to those things. So there is a secondary level and a tertiary level. So what is EDPT? You are diagnosing the disease early. What level of prevention? This is a secondary level of prevention. Giving reconstructive surgeries, free prosthesis. What is this level of prevention? This is a tertiary level. There is a third thing also. That is another strategy. That is to promote the health awareness, to promote the awareness of leprosy, that how leprosy spreads, what are the signs of leprosy, what are the features, how you can detect leprosy early, and in case there is leprosy in a patient, how to prevent the leprosy from one person to another. to the close contacts, because I told you in the start, leprosy can spread to close contacts. Usually 5 to 10% people will develop leprosy within 5 years of that close contact, right? So there are chances of leprosy to spread. But what are the ways and all these things? That is to promote leprosy. So promote leprosy awareness. So what is this level of prevention, beta? This is a primary level of prevention to promote leprosy, right? So in leprosy program, there's a beautiful way to explain that what different levels of prevention are there. So I hope you understand preventing the disease to happen. If the risk factor is there, that is a primary level. If the disease is there, you stop its progression to complication, that is secondary prevention. And in case the complications or the disabilities are there, you want to prevent the death or you want to prevent the permanent disabilities, you do surgeries, that is a tertiary level of prevention. Next MCQ is on the strategy number 3, that is awareness of leprosy. Beta, for awareness of leprosy, the United Nations, that is the big daddy, right? UN, United Nations, they launched a special mascot. Do you know what is a mascot? Mascot means any figure or any person or any cartoons or anything which represents an organization. You know that Maharaja sign, that is for Air India. That is the mascot for Air India, right? So mascot is any symbol or any person, figure which represents organization. So United Nations mascot for leprosy is a small girl child that is called as Meena. Meena, if you get an image-based question, she is always with a parrot. And this Meena is a cartoon girl child. It's a cartoon character by United Nations. So India was highly impressed by this phenomena. So India launched its own cartoon character. We have our own NLEP, has its own mascot. What is the name of the mascot? We have beta kept it as Sapna. Sapna is a school going, S for Sapna, S for school, school going girl child. So there are two important messages. One, it is a girl child, and second, it's a school going. So we are promoting the Beti Bachao Beti Padhao also thing. It's a school girl child who is trying to make leprosy awareness in the village. So it carries a lot of meaning. This whole program, the Sapna program, it was launched under a bigger program that is called as Sparsh. What do you mean by Sparsh? Sparsh is a Hindi word which means to touch. So primarily it tells you about to have less discrimination or to tell people that it doesn't spread so much by touch and things like this. But just remember, Sparsh, it is the program to create leprosy awareness. How do we create leprosy awareness? Using our mascots, either Meena or Sapna. Remember, school going girl child will be Sapna. Strategy number 4 is also to address the rising problem of the drug-resistant leprosy. It's very sad to say that leprosy, Dapsone is a very beautiful drug. Do you know that even if we put the drops of Dapsone, liquid formulation, or the spray of Dapsone, or even if we put Dapsone on the wound or on the area of the lesion, the bacterial load actually decreases, and on top of that, leave the Dapsone. If you put rifampicin, the bacterial load decreases within 3-4 days. So we have beautiful drugs, but still now we are facing drug-resistant leprosy, and they have started emerging. So what is the treatment regime for drug-resistant leprosy? Please note that in case it is only rifampicin-resistant leprosy, the drug of choice that we add over here is minocycline. We can add minocycline or we can add clarithromycin. So we have to give ofloxacin plus minocycline, or we give clarithromycin plus clofazimine, which was already given. So now in rifampicin resistant leprosy, we don't use Dapsone and rifampicin. Of course, it's a resistant. So that is for first 6 months, and then in the next months, minocycline, instead of like, you can't give both oflox and minocycline, you give either of them, and you continue clofazimine if you were giving minocycline. If it was we were giving clarithromycin, that is not given, so we give oflox and clofazimine for the next 18 months. So what is the duration of treatment for rifampicin resistant leprosy? Please note that the duration of treatment would be 24 months. So that is a sad story for leprosy, about the DR leprosy. The drug-resistant leprosy, the treatment we have to increase till 24 months, which could either include the minocycline or the clarithromycin, plus ofloxacin has to be there. Rifampicin has to be substituted, right? Next is, in case of, now the oflox resistance is also there, more than the rifampicin resistance. Now in those cases, again that same choice of drugs we have, clarithromycin or minocycline, so we give them everything together. So just remember, if you can, for the rifampicin resistance, drug-resistant leprosy, these are the schedules that you can see. Next is your strategy number 5. Strategy number 5. In leprosy, we have also started giving prophylaxis of leprosy to whom? To the close contacts of leprosy. So under the program, now we have also started giving to close contacts. What level of prevention is this? Beta, again the same answer, this is a primary level of prevention. Why? Because you are preventing the disease in close contacts. What is the drug of choice? It is a single dose rifampicin. This is a new regime which has been launched in the program. That is a single dose rifampicin. So single dose rifampicin SDR in all adults, it can be given at the dose of 600 milligrams. For 10 to 14 years, it is 450 milligrams. Below than that, it is weighed accordingly. So, but please note, it is a single dose of rifampicin. One dose. Single dose rifampicin is the drug of choice for prophylaxis of leprosy. So just to finalize and summarize what all strategies you had done. First is, we are going to promote awareness for leprosy. Awareness for leprosy. We are also giving prophylaxis of leprosy to the household contacts. Household contacts will get the prophylaxis of leprosy. We are also giving early diagnosis and prompt treatment. What is early diagnosis and prompt treatment? We are giving the multi-drug therapy, right? We are also having treatment for drug-resistant leprosy under the program, where we are including minocycline and clarithromycin. Drug-resistant, it is about the drug-resistance leprosy. And lastly, we are also offering free reconstructive surgeries and disability limitations methods. Disability limitation methods for the patients with leprosy. So technically speaking, there is a specific order in which I had written these strategies now. So what are these? These are primary level of prevention. What is this? This is secondary level of prevention, and these both are technically tertiary levels of prevention, where we are trying to prevent the deaths or the long-term complications due to leprosy. So beyond this, now I think you would like to understand and know about the WHO regime also. Please note that what was the NLEP regime? You had already seen this, that this is the NLEP regime for paucibacillary and multibacillary. In case of adults, we are giving paucibacillary only 2 drugs. Paucibacillary, we are giving only 2 drugs. In multibacillary, it is all 3 drugs. So for adult and for child, the chart that you can see on the top, this is for adults and this is for the child dose. You already know this. The WHO regime is now there in front of you. You can see that in WHO regime, beta, what we are giving? We are giving all 3 drugs. All 3 drugs is given for 12 months for multibacillary, and it is given for 6 months in case of paucibacillary. This is what is the WHO updated regime. It was launched it was recommended in year 2018, but in Government of India, we are still sticking around with our NLEP regime. Next in line is the organization of leprosy program. Please note that the organization, no MCQ on this, that it has a district level organization. There is a district program officer who is supposed to take care of all the leprosy cases and to promote leprosy awareness in the area. Next in line is what are the indicators of leprosy. Indicators of leprosy is a 3 by 5 star MCQ topic. A lot of times you get frequently asked questions on indicators of leprosy. So the indicators of leprosy can broadly be classified into these 3 topics. You can have the core indicators. We can also have the additional epidemiological indicators, and then you have the quality of service indicators. So there are many indicators. From your MCQ point of view, please note that the most important indicators are only 4 or 5 indicators which are most important. First is the prevalence rate. First is the prevalence rate. The prevalence rate of leprosy is 1. Second is the annual new case detection rate, that is ANCDR. That is the annual new case detection rate, ANCDR. That is how many number of new cases. The third important indicator is the grade 2 disabilities. DAB means disabilities. It is the grade 2 level disabilities, right? So grade 2 level disabilities which are there among the total population and also among the new cases. So please note that grade 2 disabilities we are checking. We are also checking how many new cases and prevalence rate, and another indicator you can write it for your exams is about the cure rate. How many people actually get cured with the treatment that we are giving. So these are your 4 or 5 main indicators which are used. MCQs now. Which of the following is the most important indicator? Which is the most important indicator? Please note that prevalence rate is also known as the impact indicator. Prevalence rate, that is the main impact indicator. But which indicator is the most important epidemiological indicator based on which you are going to define your services? So the number of new cases that we have every year, that is one of the most important epidemiological indicator. Epidemiological indicator is the number of new cases that we are detecting. So what are these grades of disabilities? We can actually have different grades of disabilities. The grades of disability could be grade 1, grade 2, or we can have grade 3 disability. Grade 1 disability means there is no disability, no problem is there in that patient. There could be only slight thickening of the nerves. There could be only thickening of the nerves or some problem with the nerves, but there is no disability. In grade 2, there is a sensory loss. But please note there is no visible deformity. That is, there is no motor function loss or there is no visible deformity. There could be a slight weakness, sensory loss, or there could be weakness, or there could be partial paralysis, but we don't say that there is a gross visible deformity in that person. Grade 3 means visible deformity. It could also involve your nerves from the eyes, and it could also lead to blindness. There could be so many things. So if there is any type of visible deformity, which could be motor, which could be functional, which could be blindness, so all these are grade 3 disabilities. So that's what I was talking about, the grade 2 disabilities. So once you have the sensory loss, if there is a loss of sensation in the person, or there is a claw hand, there is some problem with that patient, and if that patient comes to you, you are the director. So if you are diagnosing people with leprosy when they have grade 2 disability, does it talk good about your program? You are supposed to detect leprosy at an early stage when the patient had only lesions on the face. So please note that grade 2 disabilities among the total population or among the new cases, this is one of the most important operational indicators. This is taken as one of the most important operational indicator, very frequently asked in your exam. This is the reason I was saying it is very frequently asked, because only this point has been asked so many times. Which is the most important health awareness indicator? Same answer, health awareness or leprosy awareness. Leprosy awareness is best given by the grade 2 disabilities. So grade 2 disabilities among the new cases, among the total population, it is usually expressed as per 10 lakh population, because the grade 2 disabilities will be very low, right? So it is usually expressed as per 10 lakh population. But all said and done, just remember for your exam beta that the grade 2 disabilities are very important for us to note when we are talking about the leprosy program. So what is the target for all these? Please note that the prevalence rate, we wanted to achieve less than 1 case per 10,000. And we are very happy to say that the current prevalence is 0.67. The annual new case detection rate, it should be less than 10 per lakh population, and the current is 9.73. The cure rate is more than 95%, and grade 2 disabilities, we are hanging around 5% among the new cases. So grade 2 disabilities among newly diagnosed, among the new cases, it's around 5%. We want it to be less than 1%, or it should be lesser than 1%. But of course, that's how, there's no target for the grade 2 disability. This is the current value. I'm not saying it should be less than 5%. This is the current value. It's around 5.3%. But the targets are only two. That is the ANCDR less than 10. Prevalence rate should be less than 1 per 10,000. Please note the denominator is different in both of them. So just a quick review about the MDTs that we have in Government of India. We have for possibacillary leprosy, you remember B for bacha, B for baby, B for brown, B for blue. So in possibacillary, the blue color is for a child. It is for a child less than 14 years. It is not less than 14, it is 10 to 14 years child. We are giving a blue color blister. And you can see the white tablets. These white tablets are the Dapsone tablets. And can you see the red big color capsule? That is the rifampicin tablet. So that is the rifampicin tablet. So in a possibacillary, we are giving Dapsone and rifampicin. These are the only two drugs in possibacillary. Now showing you the multibacillary tablet. This is the multi-drug therapy for multibacillary. You can see that multibacillary therapy, we have a red color blister and we have a brown color blister. You remember B for brown, B for bacha. So in a multibacillary, we are giving all three drugs at the same time. We are giving rifampicin plus Dapsone plus clofazimine in the above said doses. Doses we have already done. I would like to bring to your highlight over here. Can you zoom it somehow? That this white color tablet is what? This is the Dapsone tablet. Can you see the brown color tablets? These brown color tablets are continuous there in the red color blister. They are intermittent in the brown color blister. Why? Because the clofazimine is given on alternate drugs. The dosage is same. Please remember, it is 50 milligram in both cases, in child and in adult. Adult will take every day, child will take on alternate days. And this is what we have is for multibacillary leprosy. The red color tablets are the rifampicin, the brown color ones are clofazimine, and the white color is the Dapsone. And you see all these are supervised doses. So every month we give this blister to the person. The first tablets, the first set of tablets, the person is supposed to take under supervision, and the subsequent they will take at their homes. Next in line that you can see over here is, you can see that this is the Sapna and the Meena. You see Sapna over here with the school bag, and she's a school going girl child. And you see Meena with a parrot. That is the United Nations mascot, and Sapna is what is the Government of India mascot. So thank you so much for watching this module on National Leprosy Eradication Program.